Good afternoon, ladies and gentlemen, and warm welcome to our distinguished panelists and guests in the room, but also online. My name is Oksana Domenti, and I'm WHO representative to the European Union, and I'm privileged to moderate today this session with my co-chair, Dr. John Ryan, who is Deputy Director General for Health and Food Security in the European Commission. Jointly organized by DG SANTE and WHO Regional Office for Europe, our session aims to capture policy, regulatory and operational changes on health security triggered by COVID pandemic in Europe, but also beyond. We will have about 50 minutes input from our panel and then give some 30 minutes for question and answer. So we are very privileged to have today a distinguished panel with also very broad geographical representation, and we are looking forward for an insightful and also inclusive discussion. So let me introduce our high-level speaker. We have with us Ms. Sandra Gallina, who is Director General for Health, Food Safety in the European Commission, and who has a distinguished career in the European Commission starting from 1988. Before joining DG SANTE at the beginning of COVID pandemic, she was Director General for Trade in the European Commission and also has worked for taxation and custom unions. Sandra has been at the forefront of the European Union response to the pandemic. And on professional, but also on personal note, I can certainly say as a person who can partner with DG SANTE, but also monitor the EU activities daily, that without her bold leadership, we wouldn't be where we are today in the response to the pandemic, but also in other advancements in global health. So we are eager to hear from you today, Sandra.
Thank you.
Bula Minister and Pacific, welcome. We're also proud to welcome Honorable Iferemi Wakanabeti, Minister for Health and Medical Service from Fiji. And in his dedicated career, Dr. Wakanabeti was always a true advocate for public health in Fiji, but also in Pacific, as demonstrated in various positions he held in his capacity of the President of the Fiji Medical Association, President of the Pacific Island Surgeons Association, and former Chairman of Fiji Medical Board. Dr. Wakanabeti is also an active member of the Asia-Pacific Parliamentary Forum in Global Health, with Fiji hosting this unique global health network last year. So he will give his perspective on the impact, response, and recent policy changes at the national level in Fiji, and also reflect more broadly on the regional perspective, including coordination and partnership within the Pacific Island countries. So Bula Vinaka, Minister, for being with us today. Over to you.
Thank you very much. And I'd like, in my turn, to introduce Jared Rockenschaub, who's the WHO Regional Emergency Director, and he coordinates WHO Europe's work on emergencies, supporting member states in their efforts to build sustainable prevention, preparedness and response, and to strengthen health systems resilience. He has a long career in WHO, working in different countries and regions, for example, Albania, the occupied Palestinian territories, and WHO Euro. Before joining WHO, he supported medical relief operations for the Red Cross in Ethiopia and managed health programs for non-governmental organizations and the Austrian Development Cooperation in the Middle East and the Balkans. And of course, Jared will share insights on changes in the WHO's work with countries, on lessons learned and on preparedness. And in my turn, then, I would like as well to welcome the Honorary Professor, Dr. Adrian Steinu-Serkel, who is a senior physician in infectious diseases, currently a senator and president of the Health Committee of the Romanian Senate, and also a professor at the Department of Infectious Diseases in the Carol Davila University of Medicine and Pharmacy in Bucharest. And a member of the Romanian Academy of Health Science. Through his political leadership as chair of the Romanian Senate's Health Committee, he instituted policy changes needed for Romania to respond to the COVID pandemic. And of course, we will look forward to hearing from Professor Steinu on the Romanian experience during the pandemic, both from the national and from the EU perspective, on how policymakers can swiftly report governments in making the changes needed. And finally, I'd like to introduce Dr. Salam Gay, who is the Emergency Director for the WHO African region based in Brazzaville. And you have a very strong expertise in health security, emergency response outbreak, epidemiology, the use of information technology in global health and health system strengthening. You've worked in the US CDC for more than a decade, including as the field response lead during the West African Ebola outbreak. You've been the Benin County representative, and you've had many other functions in Atlanta. You're Associate Director for Science in Côte d'Ivoire and Director of the Global Health Protection Program for the Democratic Republic of the Congo. So I think we have a very dedicated and very distinguished panel of guests. Oksana.
Indeed. Thank you, John. And let us, colleagues, now focus on the content of the discussion. So while we collectively work and progress to the end of emergency phase of this pandemic, its devastating impact has convened global, regional, and national leaders. And the task is to capture the window of opportunity and to jointly build a fit-for-purpose public health architecture, both at global and regional level, for a better prepared world tomorrow. So in this context, I want to explore why this response to this pandemic is a different and enduring compared to the past global health threats, and why we cannot continue business as usual. So with this in mind, I would like to give the floor to our first speaker, Director General Sandra Galina, to shed some light on how the European Union would be better prepared to respond today to the new pandemic threats compared to early 2020. And on a specific note, dear Sandra, could you give us a short overview of the main changes that were introduced as the reaction to the COVID pandemic in order to strengthen the European Union health security framework? Over to you.
Many thanks. I'm not sure how this phone works. Okay. Let me say to you, you prefaced the remark of why this pandemic is different. So I know it's not the question I should be answering, but, let me say to all of you it's different because I think people are getting fed up that a pandemic arrives and we are not ready. So, there has been this time many lockdowns and many things. And by the way, the fact that the pandemic has struck the developed countries, can we say that? Without very much taboo, people are getting worried. So, for as long as the pandemic strikes only certain parts of the world, well, yes, there are the pictures or there is a bit of help. But this time, people have understood that, this minuscule virus, stopped our lives, changed our lives. We also could not see our friends from all over the world, because, we could not travel. So people have seen that we need to be better prepared. So what did Europe do to be better prepared? I have advanced a bit this in a plenary session earlier, so I hope not to be repeating, but I will go into more detail. For instance, we had a package this time where we revisited the mandates of 2 agencies, and we had also, I would say, to revisit the way member states would work. This is called cross-border health threats regulation. And plus, we created an entity that should be dealing with the medical countermeasures and sort of projecting, I would say, possible threats in the future, seeing what we can do. So there is also, I would say, a very good work of horizon scanning and I would say determination of the measures that are needed by this entity that is called HERA. So if I were to give you more indications, first of all, I think that for the ECDC, if you read the new, I give you just a few details, but ECDC, if you read the new mandate, we have also had this idea that there will be ECDC people, colleagues going to the member states. Why is that? Because we have found, not on a permanent basis, because the budget was not there, so we had a long negotiation, so the result is suboptimal. Our ideal result was that we could be posting 2 people in every member state from ECDC. This was, very difficult because you can make the calculation is 54 resources that we don't have the money for that, nor we can afford that. So there will be some secondment in the different member states from somebody who works in Stockholm, but will go 6 months. And why do we do this? Because in many respects, there was not an ability to speak with ECDC. So it may be a possibility, an opportunity. I'm not offering it as I would say more than an advice. But if you have the language that speaks with the epidemiologists, you can perhaps have better consistency for the messaging. So perhaps even for the global, let's say, relationship, the fact that you can speak a common set with a common set of terms is better. What we did with, we also have other revisions for ECDC that are very important, such as, for instance, the fact that we are somehow having a bit of a mandatory conferral of data towards ECDC. If you may not know this, but sometimes we had to do crystal gazing ball with the ECDC because we don't have the data from the member states. By the way, it's very good that we discussed this today because the legislation needs now to be implemented. It has been all fully approved, what I'm talking about. So then we had a revision of the mandate of the Medicines Agency. Here is to expedite the analysis of and the authorization of medicines when there is an emergency. I mentioned this morning. When it comes to HERA, as I said, we have created this entity to take care of the countermeasures and not to do what I did for the vaccines. And I'm very grateful that you are so, I would say, lavish with your praise. But let me say this was a common effort with the member states. The member states were very much at the forefront. We had a very good colleague from Romania, scientist, who was helping us also in the purchases. So let me say to all of you, it was a very European experience. And I come to the regulation of the cross-border health that can be a bit of inspiration. So here, if I go really into what has really made it a bit different for member states now, is that we will have a reinforced surveillance, and this reinforced surveillance will be a responsibility and an obligation to all. For that surveillance to exist, you need to have a plan, and these plans will have to be a bit vetted and discussed with the rest of the member states, and the Commission will have a bit of a role to review them. All very difficult because nobody wants to be given bad points for the system that they have. But, the bad points sometimes are good in the sense that it comes with money that will be given to the member state to go up to the level, because we know that the surveillance, unfortunately, is as good as the weakest link. This is also for the world. It's the weakest link that will determine our, I would say, status in the end. So we need to be very, very clear there. If you want, I would also like to mention that we have kept joint procurement for medical measures. This is beyond HERA, is, I would say, within the remit of DG SANTE, which I think it's a good thing to have. Finally, and it's a point that I think we have felt very strongly throughout this meeting, we have a much more prominent role for civil society. With the revision and the cross-border health threats, civil society has its own space, its own way of influencing and determining also the process in an emergency, which I think was totally missing at the moment. Civil society was not to be seen. We could only meet them in some meetings that you would organize, but it was not a structured presence. Now civil society is embedded in the system, which I think it's very good. So I'll stop here and I'll give you more details, perhaps if there are other questions later from Oksana.
Yes, thank you, Sandra. And I have another question for you. Thank you for elaborating on the changes and the implication of these changes. And with such a breadth and depth of issue in hand in implementation, let me ask, what's your priorities, particularly related if you look at from global perspective?
Yeah. Good you asked for the priorities for the global perspective. Now, I have to tell you that we had a meeting with member states recently at my level where we went through the implementation of all the things that we need to do. And I could see the member states getting a bit worried because there's a lot of work that needs to be done. For the international level, I will mention, I would say, the early warning response system. This is something where we have enhanced it, but also with a view to have a better connection with the global early warning response system. Because, you know, at the moment, we're doing things a bit with a string, you know, a piece of string we're connecting. But here we want to have a structural connection to the global thing. And this, I would like to thank John, because it's his own directorate that is working on that and taking, I would say, the full blast of all the work that goes there. Because the key word here, which one is it? I guess you know, interoperability. You know, this is the mess. You can have the data, you can have the stuff, but then how do you communicate? You know, in some respects, it's a way of having an Esperanto. So we hope to have the way to communicate all on this, and we are working on that. Now, if I were to be frank on the reinforcing surveillance, we are having already the prodromes of what we want in the pandemic treaty embedded in Europe already, so that once the pandemic treaty will be up and running, we will already have the mechanisms in Europe. Now, the challenge there is how will we export this? I will say the truth, for me, the export of this comes with capacity building. You will not be able to have good surveillance in some places, and the surveillance is not necessarily something phantasmagorical. It's really that a doctor, for instance, in this case, I said it also earlier, looks at a patient and says, oh, this guy has Ebola, so should not be traveling. So it's really very, very basic. Let me say to you, we had trouble in Europe plenty in understanding what COVID was from the doctors. So the local level is really what we need to enhance. Now, the whole of the fifth is there. There is a lot of money. And I think if we want to really make that money go a good way, we need to help those who have, I would say, a beginning of a surveillance to go beyond the beginning and to be really, you know, on a par with the rest of the world. So for me, the fifth is very important for surveillance. There are many things that we can do, but surveillance comes first. I would stop to these two elements because there are many things that we are already projecting in the international thing, but in an emergency, talking the same language for the data and having a way to surveillance, you know, to have what is monitoring, what is happening. It's the first thing. Then, you know, we also have the medical countermeasures for which there is an international dimension too. Thank you.
Thank you very much, Sandra, for this helicopter view, looking over the 27 member states, with your involvement in managing the different stages of the crisis and particularly the vaccine joint procurement, which I think was a first for the European Union, and posed all sorts of operational and political challenges, I would say. But I think the next speaker, dear Senator, looking at the situation in Romania will be really interesting, because you'll be able to perhaps explain how the pandemic was experienced at national level in the member state. What were the key changes that you had to make in your system as a result of the pandemic? And also, how did you manage to operate across different sectors, you know, between different departments and so on? So could you say a few words on that, perhaps?
Well, thank you very much, John. Yesterday evening, I heard Sandra saying that she likes to have health for everyone. I have the same feeling. Unfortunately, it's very difficult to achieve this goal. But if we put this target somewhere into the coming future and we work together, probably we'll have this chance during our lifetime on Earth. Hopefully, yeah. When Ebola started for the first time, long time ago, I was the manager of a National Institute for Infectious Disease in Romania. And I sit on the chair and say, what are you going to do? And we wrote a program to build the facility with laboratories and P4, P3 biosecurity level for the case 0. Yeah, I don't know if you remember what that means, case 0. We didn't remember, but we done this facility. So when the pandemics came up, we had the possibility to isolate it, to identify the first case and put it in this kind of facilities and train our people, our staff, how to deal with. Yeah. Previously, we had a lot of other exercise, how to dress, how to undress, because when you undress the protection equipment, there is the moment of contamination of the stuff. So we had this lesson previously. So we replicated to all our sites in Romania. We have a network for infectious diseases, and we intend to maintain this network for infectious diseases because with the hospital, in the 9 specific regional centers, we've been able to attack for the first time this pandemic wave. So all the patients were directed to this kind of facility for infectious diseases. So in my opinion, the member states which don't have this specialty in their yard, it's time to do it because this is not the last pandemic. Probably will be the last pandemic for us, but the next generation, for sure, they will have a pandemic. And by the way, the pandemic didn't knock on the door, say, okay, pay attention, I will come in your country next week. So prepare, I leave you 1 week to prepare for, no. So we have to imagine in this very moment what we can do for the coming future to train the other people with what we learn in this pandemic, and we learn a lot, yeah, and to give them the possibility to put in their mind. If we don't do like this, it's penance. Otherwise, we have a lot of problems with those who criticize the vaccine. Everybody right now knows what the vaccine is. I done an experience. I took the vaccine book, I put it in, and I weighed it, 3.5 kilos. With thin paper, yeah? I say, okay, the person which at least opened the big book in this very moment has the possibility and the right to talk about vaccine. Otherwise, shut down a little bit.
It's very good. It's very visual. You did that on television?
Yes.
Very good.
But nobody pay attention. When I came back in the Senate, one of my colleagues said, wow, Professor, it's not right what you said. The vaccine killed the people. Oh my God. What am I going to do? So it's a truth of a specialist against the opinion of somebody which has no connection with medicine.
We need a session on this.
Absolutely.
How science is communicated.
So here we have to work also together, and the Commission can do a lot of things in this direction because the good information, the clear information, the spread of the good information will hit against anti-vax. Anti-vax perform a woeful problem. I have the experience from the hospital because as physician, I've been in the hospital in this period of time. So all the patient, let's say 98% of the patient which was admitted in the intensive care unit die without being vaccinated previously. Not a single dose, because they have the conviction that the vaccine is no good. It's too early vaccine. The technology is there. Yeah. How to explain about RNA messenger RNA? It's a message that the RNA give to the cell. It's just a message, yeah? When I had a comparison, when you go into the airplane, you are not wondering how type of engines the airplane has, how many engines, if the pilots are trained or not, if the stewards are like, okay, fit it and so on.
Mentally sane.
Yes, men say, yeah. So, but everybody jump into the airplane.
Thank you very much, Adrian, for this overview and very much your. I really hear the voice of truth there and the experience that you had at the national level. How would you see the added value of having a European legislation in this area? Do you see that as a value added for Romania? And do you also think that this might help with the relations that you have with neighboring countries like Ukraine or Moldova? So what would your appreciation be of the advantages, disadvantages of having a European regime?
Well, unfortunately, in this very moment, you know very well that Ukraine is under a Russian war. And we had to organize very quickly for the coming transfer people from Ukraine in the many centers. So first of all, the civil society was on the border. Then the Ministry of Health with the specialists came, blah, 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 and to see, to screen, to test. Blah. But when we go there to test and to screen, our friends from Ukraine said, okay, I don't like to be tested. And this was the problem. You discussed about how you may collect data. First of all, somebody has to be there to collect it. And the second step, somebody has to put it on a computer. So the digitalization might be the answer to your question, how we may collect data. I absolutely agree with you that there are some problems there with TB. They had some problem also with diphtheria previously, and we've been aware, and we try to train again our staff how diphtheria presents as clinical point of view, because it's the first step. Yeah, and fortunately till now we didn't have any problem. Everything is under control. The system is fully operational. Right now, we are in discussions with the Republic of Moldova, because you mentioned also Republic of Moldova, because a lot of people transit the Republic of Moldova. I came into Romania in the south. So we enlarge other sites to receive this population and harbor there in our country with all the facility for the various moment.
Thank you very much, Senator, for these perspectives. Oksana?
Yeah, thank you very much, Senators, for your perspective, indeed very insightful, and also for your leadership in Romania, but also for your support to neighboring countries. We know that it was very important and tremendous during the pandemic, but also now during the recent challenges related to the war. And now let me move to another region. And I would like to address you, Honorable Minister Wakanabete, and ask your insight. What is your lesson learned from this pandemic, from your national perspective, particularly now? And speaking about vaccination, we would be also very much interested to hear about Fijian no job, no job approach.
Yeah, thank you, and thank you for having me in this discussion, and the pan-European global health security policy changes. This discussion, and obviously I'm not from Europe, but there are many similarities in some of the responses that we did with COVID-19. Now, Europe is unique because you've got the European Commission. Fiji and the other Pacific Islands, we are a regional, but not as closely knit by a border as you are, and also by the frameworks that you have, such as the European Commission. We are also sovereign nations. And I think that's something that I continue to think of when throughout this conference we've been talking about regionalism and globalism. We also have to understand that every country is a sovereign nation. And so in the Pacific, the great thing is everybody is second or third cousin or fourth cousin of somebody else. That actually helps. The culture helps. The ancient traditional relationships helped. And that worked in our favor in terms of being able to come together, obviously virtually, and agreeing on some of the things that needed to be done. We quickly worked on our lab. We've been working on our lab for quite a while. We quickly accelerated the work on our lab so that we can be able to test COVID-19. And we were one of the first in the Pacific to do that. And then raising it to a CDC level, not necessarily the lights and the bells that you may have in the European CDC, but adequate enough to be able to support the Pacific. We also worked with New Zealand and Australia, our key partners, and work with them in terms of how we can be able to respond. Now I'll talk a little bit about response. As you know, Fiji is directly in the center of cyclones. We had Tropical Cyclone Winston, which was the first Cat 5 cyclone to ever hit landfall and hit Fiji in 2016, wiped out 25% of our GDP. And that was in 2016. Ever since 2016, we've had 14 more cyclones, another Cat 5, several Cat 4. And as you know, we champion climate change because obviously that's what's bringing these cyclones. So disaster response has become part and parcel of the Fijian government's forte. So disaster response. So we know how to respond to disaster. And so what happened was, we then, during this COVID-19, we utilized the science that we have from our medical experts working with WHO and other stakeholders. And then we brought it and gave it to the disaster response group. And the disaster response group is a whole of government approach. And they drove them. Now, remember, as I've said before, we respond naturally to disaster. So now October to April is our cyclone season. So already now our disaster response NDMO is already meeting. So that same group, we then take it to them. We said, okay, this needs to be done. Of course, we're going to have a lockdown, but we need to feed the people. We need to ensure that the groceries are met, and the disaster response group did them. So yes, we did have some preluding experience, just like you had in your preparation, not necessarily completely medical, but remember, COVID-19 was not only a medical problem, it was an economic problem. It was a social protection problem. And the disaster response helped us in that regard. Now, we are very dependent on the tourism market. And I'll tell you a quick story. Last year was one of the best times for the forestry. We have a lot of mahogany. So at the end of the year, we cut down, and they said, by November, they said, we're very happy. We've made 117 million Fijian dollars. We opened our border in December. We had 33,000 tourists. We made 120 million in December. So you can see the tourism, just in December alone, exceeded what forestry earned the whole year. Now, so we needed to ensure that we quickly open our tourism market, because that was foreign earnings for us. And working towards that was one of the reasons why. And also we need to ensure that we got people back to work. Because certainly we are a small nation, we don't have the capacity to be able to keep them on social protection. And right in the middle of the second wave, when we had a lot of people with the transmissions, with the lockdown, that's when vaccines came through. And we also saw that there were some regions around the world that were beginning to make vaccine mandates. So that's when we made this bill and took it to Parliament, and we inserted it into the Occupational Health and Safety Act, where in that bill is what we call the vaccination bill, where everybody that goes to work must be vaccinated. So I know that there are countries that have said in the service area, people working in the hospitals and also in social protection, they are vaccinated. We said everybody that goes to work must be vaccinated. So we did that. And obviously there are exemptions that can be done. Obviously the Ministry of Health has a right to be able to exempt somebody. But that was the reason why we were able to quickly have vaccination. So now I've been told 103% has been vaccinated first dose. The 3% must be the people living in Fiji who come from other areas. But our second dose has been well over 95%. And we're going through our booster doses at the moment. So in summary, one, we've had experience, not necessarily completely medical experience response to the pandemic, but we must remember the pandemic is more than health.
Yes.
Is more than health. And number two, we didn't, of course, we had the no jab policy. We had to take it through Parliament. We had to get people on our side, but it was done so that we save lives and save livelihoods. Thank you.
The Minister, I have another question for you. I would like to invite you to share with us some regional perspective in the Pacific in your capacity as Minister, but also in your capacity as parliamentarian and member of this Asia-Pacific Parliamentary Forum on Global Health. And I was very privileged to join the last meeting of this Parliamentary Assembly, and I saw you have advocated during the debate for closer cooperation with the European Union. And I would like to ask you why you consider this important.
Yeah, thank you. Look, our traditional partners are Australia and New Zealand. There's about nearly 20 countries in the Pacific. And we obviously have to also look outside of them for multilateral partner support. And I've just said, we've had 14 cyclones. Our Ministry of Health, facilities, we repair them, next cyclone comes, they go down again. So we need support. We need financial support. We need resources as much as Africa does need them. Now, the reason is very simple. A lot of the small island development states, we rely on tourism. Where do the tourists come from? From Europe, from America, from Australia and New Zealand, from first world countries. So when you are supporting us, you're also supporting your people who come and visit us. That's important. Thank you.
Wow.
Thank you very much. It's really been interesting to listen to the helicopter view from the European Union to the experiences in Romania and now the experiences in the Pacific and in Fiji, really different perspectives, I think, on the same problem. But now it would be good, I think, to go to WHO Euro and to speak to Jared Rockenschaub. And Jared, can I ask you to reflect on how the COVID-19 experience has changed the WHO Euro activities in supporting its member states? What are the key lessons that you've learned? We're trying to learn lessons as well in the European Union, but I know the WHO has also been reflecting on this.
Let me try, John. But before doing so, let me start with thanking Sandra Galina. I think, first of all, for the really excellent speech yesterday, which I think was really spot on in pinpointing some of the challenges and some of the key priorities we need to focus on moving forward, and also for organizing this session, because there is a lot of discussion now on the global health architecture, the INB negotiations, the targeted amendments of the IHR, and the global health architecture for health emergency preparedness, response, and resilience. But I think we need to also have a debate and a discussion. How do we set up our regional health architecture? And a lot of it is obviously happening at the EU level. But coming from the regional office, we have this other part of the European region. We have the 27 EU countries, but then we have the pan-European context of the 53 member states. And we need to look at, and unfortunately, the Ukraine war didn't necessarily make our life easier in doing everything possible that we don't create any blind spots for future pandemics in the rest of our region. And I think we really need to focus. Now, how has this changed our perspective of working in the European region? Office? Well, in WHO, we always have the debate, are we a standard setting organization? Are we an operational organization? Well, I think we're both. And I think COVID underlined the importance that we need to do both and both in a really decent quality. And one of the steps that we initiated initially was to establish an incident management support arrangement, that because we clearly quickly understood that this is way beyond the emergency program as such. It really needs to, the engagement of the whole house. So we structured our work of country support along the technical pillars, from clinical management to procurement to misinformation, communication arrangements, and so forth. And we try to replicate this also in our country offices and also in the member states. I mean, we were trying to push the notion of public health emergency operations centers, where we can collectively have an operational platform that brings together the multiple sectors. And I'm very grateful to you, Minister, for highlighting that disaster crisis management experience helps in managing every crisis. And I think we need to learn the lessons. I think in moving forward, we really need to make sure that we look at a multi-sectorial approach. I mean, it's clearly not only the business of the Ministry of Health to manage future pandemics. We need to have other sectors engaged. And I think we need to also look towards other hazards. I mean, it's not necessarily a given that the next major crisis is going to be an outbreak. I mean, we also have earthquakes, floods. We have other hazards that we need to be equally prepared in moving forward. I think we have a very small window of opportunity, and we need to use this window of opportunity. Health is still high on the political agenda, but we know that, this quickly disappears once, a crisis fades away, and we are fortunately making some progress with the pandemic, although, we still have 36% of all the cases in the European region at the moment of all COVID cases, 28% of the global mortality. So this is not over yet, but I think we're going in the right direction, and obviously we're much better set up, and immunity levels are high. But still, we need to harness this window of opportunity. We need to move forward. We have new arrangements in place, preparedness arrangements that would allow us to respond much more effectively into a future crisis.
Thanks very much, Jared. I think I hear the voice of experience here, and political priorities move on. And how long are we going to have the political spotlight on health? That's the question. We were talking earlier on about the new European legal regime on cross-border health threats, which includes a very strong preparedness aspect. How do you see the interface with WHO Euro in that respect?
I think we see the EU and all institutions there as a very strong partner that, will help us to address also the challenges in the rest of the region. And I think we feel that we need to move now, and we are trying together with our regional director to push this notion with Hans Kluge of preparedness 2.0. Basically, what do we mean by that? Well, first of all, I think we need to quickly move in implementing some of the Monti Commission recommendations. And obviously quick win. I think it still takes its time is obviously the One Health approach that I think many have highlighted the importance around that. The other one is that we have this notion of a pan-European network for disease control with a strong partner of the ECDC, but then also engaging institutions in the eastern part to have a coordination platform to avoid any blind spots in the future, to have collaboratories, as we call them, expert exchange, networking, and so forth, to build the relationship. And then I think we need to have a strong focus on having national emergency preparedness plans in place. And I think that's one of the focus also of this new EU health security initiative, where I think it's a given that we need to collaborate on that. We do have some tools in WHO, the national action planning for public health security that we want to push. And perhaps the last point, if you allow me, I think we need to push a global health emergency workforce. I think many of the issues and challenges we were facing were due to workforce related challenges. And I think we need to collectively address that. I'm just back together with Mike Ryan from the Global Emergency Medical Teams conference in Yerevan. This is one initiative where we have 20,000 trained emergency workers that can be deployed from member states. We have GOARN, we have other mechanisms. We need to bring that together to have a global health emergency workforce that can be quickly deployed based on standardized standards and quality standards and help in future crises.
Thank you very much, Jared, for this perspective, and I hope we can continue to work together across the European Union using the tools that we have in both organizations. I think it's worked in the past, and we certainly need to work together on surveillance and response, risk assessment, and so on. But I think it would be useful now to bring in the African perspective, the African Union perspective as well. So, Oksana.
Indeed. Dear Director Abdus Salam, I really would like also to hear from your region which kind of transformation and also innovation pandemic has triggered in the African region. If you can share with us, please.
Thank you, Roxana, for inviting me, and also thank you to all the panel members that I have the privilege to talk with. Just to talk about Africa in terms of outbreak and emergencies, it is 2 emergencies per week. And currently, I am following or monitoring 147 emergencies in Africa. And over 70% of them are about outbreak. and each outbreak may go to a level of pandemic. It is also some emergency that could be avoided. I came recently from the Gambia, where 70 children died because they used medicine that was of low standard. And it is related to climate change because they have some flood, and the flood created some infectious diseases. The parents went to see for medicine and got into those medicines, and the children died. And all those are lessons to be learned. And when you go to Africa, the head of state and all the leadership realized very quickly during the COVID-19 pandemic that changes need to be done. At the country level, they are being done. And most of the time, the policy was not adequate enough because they had to go to declare a state of emergencies in order to be able to make the measure they needed for COVID. And after that, they moved that to a higher level. For example, the economic, the regional economic committees like ECOWAS, EAC, SADC, and other entities start developing capacities on surveillance, on other public health. And like ECOWAS already have WAHO for a long time, but the other regional economic committees did not have agency in charge of health. And all of them today are looking for creating their own agency that are related to the committee. When you bring it up higher, the African Union has learned a lot. And during the last 2 years, I thought that it is the time where the creation of new entities to support is the most. The African Medicine Agency has been signed by many countries, and it's going to be implemented soon. There is also the African Humanitarian Agency that is in creation. And most of all, there is the champion of now, which is the Africa CDC. The Africa CDC has just 6 years, but the COVID-19, they had only 3 years at that time when it started, was for them like what Winston Churchill was saying, never let a good crisis to waste. Mm-hmm. They use the COVID-19 as a way to affirm their capacity and also to get respect from all agencies, including WHO. So there is also some other action that are being done on global activities like the International Health Regulation Amendment, where we negotiate with countries that are putting amendment like the US. But also there is an amendment now that is originated from Africa under the leadership of some countries like Botswana, like South Africa, Ghana, that are working in order to make sure that the amendment of the IHR take into account equity. And the amendment of IHR, when we are talking about data sharing, we also talk about benefit sharing. Because when many vaccines are developed and some of them tested in Africa, when the benefit comes sometime, we are the last to see it. There is also the INB negotiation where in WHO Afra, there is a task force to support our government, contribute very positively to the change that need to be done. So there is a lot of things that are being done after and during the COVID-19, and many of them are now very developed, but not finished yet. And I hope that they all will be finished for the benefit of saving life and reducing pain.
Thank you, Director.
Very good.
And I also wanted to ask you how this changes that you mentioned has impacted your work with countries. So how you are helping countries also to incorporate lesson learned and to change this lesson learned into the practical solutions. And if you can also elaborate a bit how also pandemic has changed or developed the relationship and the cooperation between WHO and European Union and African Union.
Thank you very much. The first is that I need to thank European Union. What we have seen during the COVID-19, and particularly in the relationship with regional entities, has been really a very equilibrated relationship. when African Union and European Union are working together in order to develop guidelines, but also in order to share capacities and experience. It is some win-win and really a very equilibrated win-win. I'm giving as an example the support of European Union for the mRNA development in Africa. There is also the very strong support of Africa CDC that European Union is supporting. When I say that Africa CDC has been the champion of COVID, and it is not completely, but thanks to European Union support, whether it is resource support, but also the support in all the platform. And also European Union is supporting WHO Afro in making sure that health systems are strengthened in our countries. So what we have learned is that in many countries now, health discussions are happening at the State House. It was not happening before. It was only about the Ministry of Health. This is going to push to decision-making that are going faster, resources mobilized, and also it help the government to know that health is not only a matter of technical, but also it is a source for them to build confidence with their population and also to get vote, because that's what they want. We work a lot on other aspects like workforce, coordination, community engagement, and supply chain, because the supply chain was the weakest link when we were responding to COVID-19. Thank you.
Thank you.
I think ECDC is working about this.
Thank you, dear Director, and thank you to all the panelists for your insight. And now I'd like to turn to the guests in the room and to thank that you have been patient, and would like to invite you to share with our panelists your thoughts and questions. So please raise your hand and please introduce yourself when you ask question. So please, right here. You are the first.
Thank you. My name is Nima Lugangira. I'm a member of parliament from Tanzania. And I wanted to ask a question. This is particularly to Madam Sandra. And the issue is generally on health equity. I'm coming from obviously a developing country, but also coming from a region which is a peripheral and border region. And oftentimes I see a lot of health interventions that come into developing countries tend to forget peripheral border regions. And as we have seen in the case of COVID, and even right now we're seeing in the case of Ebola, that there are higher risks by continuing to forget us from border regions. So I just wanted to hear from Sandra, what is your opinion towards ensuring that we achieve health equity and not leave anyone behind? Thank you.
Collect a few questions.
Yeah, we can collect a few questions. Yes, please go ahead.
Thank you.
I'm Dr. Eleanor Wadinobi. I'm the International President of the Medical Women's International Association. And thank you to all the panelists for your very illuminating presentations. I'm encouraged by the level of frank conversations that are going on at this summit. And taking my cue from being frank, I'm a bit concerned that we are speaking today about a pandemic treaty. And I'm a bit concerned that it looks like we're going down the lane of siloizing again. And what do I mean by that? Prior to the COVID-19 pandemic, we had, as WHO has told us, 1 in 3 women and girls suffering one form of violence or the other. Those are pandemic proportions. When COVID made landfall, we were told by UN Women that we had a shadow pandemic because women and girls were locked down, locked in, locked away with perpetrators. And I would therefore like to see a treaty that is holistic, a treaty that is inclusive, because it wasn't until COVID-19 happened and there was an enormous escalation of violence specific to women and girls that we had examples of hotels being converted to shelters. Surely the world should have been prepared for the escalation that we saw in those sorts of violence. And even when this particular pandemic dies down, and we're talking about preparing for another, we will still have, unless the text is embedded and enshrined in the upcoming pandemic treaty to address this shadow pandemic or the pandemic within the pandemic. We want our governments to negotiate a treaty that has an inclusive text of all that affects every aspect of health, especially mental health. Thank you very much.
Thank you. Yeah, we have more questions here. Thank you. Yes, I'm Dr. Milka Sokolovic from the European Public Health Alliance. I must say I'm somewhat embarrassed for the lack of the out of Europe views, and I find this conference very insightful and inspiring. I will still turn to Europe, so my question is directed to Sandra Gallina. Well, first of all, I can nothing but commend the Commission for extending the mandate of ECDC, of the EMA, for establishing HERA. Also, yes, to the more engagement with civil society, and let's make then the next step for more meaningful engagement with civil society. Yes. And yes, to a session on better translation of science into practice. So let's see, how do we communicate in a better way so that people can hear the science? Now, my question goes about the effect of COVID that was unveiled, that has unveiled the very close interaction between communicable and non-communicable diseases. Yeah. And also COVID has unveiled a very complex gap in health equity. So my question for you, Sandra, is going forward, how will Europe work on raising preparedness for these issues? Thank you very much. Thank you, Milka. And I think we have one more question here from Georgia.
Miriam Jeshi, the global board member for Unite Parliamentarians Network for Global Health. We're just coming from the session where we were speaking about the pandemic treaty and the role of parliamentarians, how we could participate in negotiating the different details. And I would like to also speak from the perspective of the former Minister of Health in charge of the national CDC operations. What we have seen during the pandemic is definitely the need for robust surveillance systems. Absolutely, yes. But we have also seen political impact on the decisions taken by the governments. In the name of the pandemic control, we have seen actions that were not evidence-based, not following WHO recommendations, and most importantly, the decision-making process of the interagency coordination councils were hardly engaging opposition political leaders or public health experts. So the national decisions were not really owned by different stakeholders, and that was a missed opportunity. And one of the reasons, like underlying factors, was the lack of the global effective monitoring or even the inspectorate system that could ensure consistency of the national actions to the global recommendations. So I'm also delighted to see the expansion of the ECDC mandate, because we need stronger European CDC and stronger presence of the European CDC, both in among the 27 countries and beyond. And stronger collaboration of CDC Atlanta, European CDC, WHO, to really form the multilateral global health inspectorate that can really, in a positive and supportive supervision way, support and strengthen the national health authorities. Thank you.
Thank you very much for your comments. And I think we have one more question here.
Thanks, Oksana. Temo Wangariwalu from WHO in Geneva, in charge of non-communicable disease. Just want to build further on the two questions. We haven't heard it from the panelists, maybe because Oksana didn't really ask it. Lessons learned for non-communicable disease. They say outbreaks cannot be prevented, but needs to be controlled. And part of the control is preventing deaths. And apart from those not being vaccinated, probably 90% of those underlying conditions, which is mainly non-communicable diseases and mental health. So just the lessons learned in really controlling non-communicable disease, because then you prevent death. I know for Fiji and the Pacific, it's the epicenter of NCD probably, and in Europe, but Salat, Abdul Salam, in Africa, your SADO epidemic is non-communicable disease. Highest rate of obesity increase is in sub-Saharan Africa. So unless that is actually handled, then the deaths and all due to non-communicable disease continues. And maybe, Sandra, from the European Union's perspective, thanks for the UHC partnership, which is building health system to strengthen, to be able to withstand the NCD. What are the lessons learned that probably can contribute to the control of now and the future outbreaks as well? Thanks.
Thank you, Timo, for your comments and question.
Really
I'd like to ask our panelists, do you want to reply now, or we can collect all questions and then?
We can reply now.
I think this is a fair share of questions. I don't know if you have many more. I think this is at least for me, it's enough. But you know, they may wish to have more questions. Huh?
Thank you, Sandra. Then I'm turning to you.
Anyone wishing to volunteer? I see all trying to find it. So I'll break the ice and then you can come in, because I think there are many things that we can integrate.
Yeah.
So, and also because I don't have all the answers, but I have a lot of enthusiasm to work in this area. I'll take off the mask. I'll go, of course, I'll deal with the question of the peripheral border areas first, because we had in Europe some such experience, whether you believe it or not. So let me go. It's a different experience. You were forgotten. The peripheral or border areas in Europe were punished, meaning that and here I mix up with the other question on the cacophony of messages that were coming out from, the very beginning. And I'm sorry to say, we tried our best. The Commission was trying to give communications to say, wearing masks is perhaps, useful here, there, and everywhere. And we had a long list. John can give you the catalog. I don't know if we produced 23 communications. I don't remember anymore the number. It was huge, the number. We were instigated all the time by the president, say, but what are these guys doing? And so we would say, well, we'll produce a communication. On top of that, ECDC was also producing very clear guidelines. This is useful, this is not useful. So the border areas, there are many people that commute between the borders in Europe to somehow work. This has been the first population that was affected by the lockdowns or the disparate measures. So, one country would be doing one thing, the other country would be doing another thing. And these people then had to raise this issue at political level. It would arrive really very high because it was interpreted really like disloyalty to the European Union. So there we have still today something that travels in space, which is my dearest colleague, Director General Hall, produces every week the pandemic report for the green lanes. What were these green lanes? You need to remember that some unsung heroes of this pandemic were truck drivers. Truck drivers that were trapped in borders. You have no idea the long queues that these guys had, and without water, without anything. I may say also in the middle of winter, because this was not still the season. So let me say to you, in terms of forgetting the borders, I think that this belongs to a government not to forget the vaccination or to measures there. I am confident that a CDC in Africa is not forgetting the borders. Nobody's forgetting the borders. So if the measures are not arriving, well, I think there is democracies in the world, and you can somehow make your feelings felt. But the borders in Europe, a continent that was free, were a total disaster. There was, at the beginning of the pandemic, a whole set of measures that were destroying not just the single market, but the free circulation of people in Europe. So let me say to you, it's a lesson. We learned the lesson, so we know we don't want to go there anymore. And I know that EAC, the Eastern African community, you have very close bonds. I must say Tanzania is a very advanced country in terms of health. You may perhaps be missing some of the money that some other big neighbor has next to you. You're very big, very voluntaristic, and you need more support. But Tanzania is very good. And so it's maybe attracting even people from outside. So for me, the borders, it's a lesson. You need to remember that they are not just a problem in migration. They are a total disaster when it comes to health. These borders just don't make sense because the virus would be traveling everywhere. So I hope I gave you also the feeling that borders is not just Africa. It's also in Europe, that we pretend to be, in a single market. We were not. Then the pandemic treaty, silo, very good suggestion that you're giving us. I'm not so sure about including the topics that you said, but this is a concern that I have, that after the pandemic, the whole of government approach, it's a bit going away from us. First, because of necessities, and I heard about, the pan-European complexity. We have war, we have to deal with refugees, we have to deal, and I would say that the aggression of Russia has created enormous trouble in Moldova, very, very weak country, in Romania, I would say, but also in Slovakia and all Poland. Poland is receiving a number of people that, it's incredible. So let me say, we are bearing the brunt of this aggression. So again, it's beyond the borders. And the pandemic treaty, I'm not too sure will be able to encompass all the aspects that, we live in a pandemic. And, some of these aspects pertain to the disaster part. So I think Fiji was much better prepared in some respects than us, because we were going with health measures, but, this was a real disaster in the pandemic. To have elderly people isolated in homes, how to bring the food to them. It was a whole set of issues that we were not prepared at all to face. Where are we prepared today? I'm not too sure about this. This is why I say that holistic. We created things, we created HERA, we go with things. But if pandemic were to strike again, what do we do with the elderly that need to be? And here I go to the last element, which is really a bit of a complicated lesson that we have not learned, which is the non-communicable diseases. So we go in circles here. First, we go with the pandemic. I think it was a disaster. There are even figures that have shown how many cancer cases have deteriorated because the screenings did not go on. John is dealing with this. He can even give you figures about this. But let me say to you, we know I'm not too sure that we did a lot, to be very frank, to cope with the non-communicable diseases again in the pandemic. I will be very frank. I have the impression that this is a blind spot yet, not because we don't know about it, but I'm still not convinced, but John can deny me. Did we do a lot on this? I don't know. The silent pandemic of obesity, especially in children, I witnessed it in Italy. I was in Washington last week, and I must say the number of obese people that I have come across, it's really striking, especially, I would say, amongst the people who are working in lower paid, even in a hotel, you can see those who are at the reception are not of the same weight as those who are cleaning your bedroom. So, you know, the cheap junk food is still going around, and I think all countries have a challenge there. So I will be very honest with you. There should be for all these I would say silent pandemics of non-communicable diseases, there should be a bit more of a center point also in WHO. I know that WHO region Europe is doing a lot. And I finish with one topic that has not been totally raised, but you know, you mentioned it, that this is the mental health. Mental health in COVID was a disaster. I think that we all, I don't know about you, but I do believe that it made something to me, obviously not to go into the pathological side, but it's really changed me. These 2 years of not seeing my family because I was stuck in Brussels. I had not gone back to my family for over 18 months. It was really very, very hard. So did we do a lot? Well, we are trying to go with initiatives like Living Healthier Together. We will have, I would say, a more comprehensive approach in the Commission on mental health, because this affects working conditions, it affects children. So it's well beyond just simply health in mental health. It's but I will not lie to you. I don't think we have learned the lesson for NCDs, or I would say for mental health. We're taking one step at a time. And I must say I'm admiring our African colleague here, because when he says that there are these huge numbers, I really don't know how you cope with these huge numbers of, I would say, real emergencies, you know, 140, 70 of them potentially a pandemic. I really don't know how you can stay so calm. We in Europe, you know, when we have one minor outbreak, and, you know, it's funny because I deal with food safety. For food safety, I can do things that I cannot do for human health, because the competencies of the European Commission are much bigger for food safety. So I know very well that when I have even a small salmonella case, I'm going ballistic. I say we need to block this now. And, you know, it's a very stressful moment. So I think he deserves praise, and all our African brothers deserve praise for all they do to cope with this, but you know, we need to help you cope much better. So I'm fully thinking that we have a responsibility there we need to attend to.
Thank you so much, Sandra, for this global perspective and complex answer. And you told you are not doing enough for NCDs, but we see a lot of progress also in your activity on cancer area.
Of course.
And also, some joint action on NCD, and I really want to praise your team also for the work in this area.
I'm not here to make publicity. We're doing a huge program on cancer, which is called Europe Beating Cancer Plan. It's really huge money. It's done also with research, so we can speak about the good things there. But in terms of the rest of the NCDs, it's very complex. It's very complex.
Thank you so much. And I would like to invite maybe other panelists. Professor.
Well, that concerns the non-communicable diseases. It's a very nice and interesting situation, because we learn a lot during pandemics. We learn how to develop new circuits, how to take in charge our patient, how to direct them. But at the same time, we have to figure out that we have at least two types of medicine. One type of medicine we refer to the rural area, and another one to the urban area. So those which are in rural area has a very poor access to the healthcare, linkage to care. We like to this linkage to care, quality of life, blah, 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 blah. Well, I think that we have to redesign in our mind how a health system is supposed to be. And in this context, we'll have also infectious diseases, transmissible diseases, and non-communicable diseases, what we know in this very moment, due to the fact that in our body and on our skin, we have 10 more times more microorganisms than our proper cells.
Yeah.
So this is the situation in the very moment. Thank you.
Thank you, Professor. And the Minister, please.
Yeah, thank you. Again, going back to the NCD, there was an article in the Lancet which looked at countries that were lagging with their normative work, which included work around NCDs because of the COVID-19. And again, it showed that, again, some developed countries and a lot of developed countries, just like low middle income countries, we all struggle. We all struggle with our normative work. That's proven. And they've written an article about it. One of the countries that actually did quite well was Korea. So I did ask them, how did you do it well? Well, obviously, they've got a different sort of system. They've got a suburban hospital, really. So that seemed to help. What is very clear, though, is it's not only NCD, Temo, it's actually everything else. The expanded program of immunization, EPI, the surveillance for, other things. So all the other programs of the ministries of health have actually gone backwards. And one of the things I'll be talking about tomorrow in another panel is that what we've talked about in Fiji, we said, how cyclones, we've accepted cyclones as normal, and we do disaster response, and that's normal. We said funding for it. We need to make pandemics a normative part of our work. Because as long as we keep it an extra normative part, then we'll always be playing second fiddle. So, and again, for a country that's resource limited like ours, it's a difficult challenge. But we accept that has to be the way. Because unless we make responding to outbreaks, responding to pandemics, same as we do with cyclones, and put it into our normative work, then we will not lag the next time around.
Not to be totally disrupted by that and to continue. But I cannot say that I have that for Europe now at the moment.
Any other colleagues would like to?
If I may, I would perhaps like to pick up your very challenging point on the pandemic treaty, and perhaps I would like to see the glass half full rather than half empty. I think we have the chance that this is a very comprehensive and inclusive process. It's a bottom-up process. It's a member state-driven process. So there are ways in democratic countries to channel the messages to the top and make sure that those issues that you raised get voiced and eventually embedded. Now, will the pandemic treaty be able to resolve all the problems in the future? Probably not, but I think it will at least allow us to take some of those things forward. And, the issue of women and children, I think is certainly something that needs to be voiced. And then there are mechanisms, there is broad community consultation. So I think there are opportunities to get that involved. And we have in Europe even now created a platform at the regional level to make sure that, countries can voice their concerns and those issues can be better integrated. It is obviously a very challenging process, and particularly for smaller member states. Many of these negotiations take place at the Geneva level. Not all Geneva missions have the right capacities in place, and not all ministries of foreign affairs have the luxury of having a health attaché who can follow all these negotiations. So I agree there is huge challenges, but I think there is also opportunities in taking this forward. And on the non-communicable diseases, I think this is a real issue, and I fully agree that we were not able to tackle that sufficiently. I think what we are trying to promote, and our regional director always mentions, that is this dual track approach, that we need to focus on strengthening the emergency preparedness and fully focus to address the challenges of the ongoing emergencies, but at the same time, make sure that, the essential health services keep functioning. And that's exactly where I think, communicable diseases management needs to be prioritized. And I mean, it was Richard Horton, I think, who wrote an excellent editorial about this dual pandemic, that, it's not only a pandemic of a communicable disease, but it is combined with the non-communicable diseases that makes it so disastrous for people's health. Yeah, syndemic, exactly.
Thank you very much to all of you for your questions, comments, and for your answer. And our organizers ask us to finish on time, and I think we'll stop here the session of question and answer. And I'd like to hand over to John for some conclusion remarks.
Yeah, so it's been really interesting. I've been sitting here for 2 days now, or 3 days, participating in different sessions. This is really an interesting one, because I think the geographical comparison is really stimulating, I would say. Instead of being among ourselves in Europe, we're really seeing the experience, first-hand experience, I would say, of colleagues working in different regions. And that's very enriching, I think. And that's a value added for this type of event. So thank you for participating. I just picked up a number of points. First of all, I think it's really important to learn lessons when we can, because we're going to go on to something else afterwards. And that's my experience anyway, that something else will come along very quickly, and we'll think of COVID as ancient history, So let's try and build on our experience and try and learn lessons when we can. Since our colleague from Africa quoted Churchill, I will quote Jean Monnet, who is the founder of Europe. He said, "L'Europe se fera dans les crises et elle sera la somme des solutions apportées à ces crises." So we have very much this idea in Europe of trying to learn lessons from a crisis and trying to embed these lessons as best we can, either in legislation, in treaties, in new investments, that sort of approach. So I think the European Union public health history is based on, different crises over many years. I noticed that there was quite a focus on science-based measures and the need for science-based measures. And I think that's our first line of defense, actually. I won't say against politicians, but to convince politicians that they need to do something. If you have a solid scientific base and an argument, if the measures are proportional, then you have a very strong chance, or a stronger chance, I would say, of getting those through against lobbies who may not be lobbying in the same direction as you. So I think the minister from Fiji was talking about the tourism industry and how much the tourism industry represents. We had the same problem in Europe, that our tourism industry was basically shut down for months. So when you're talking about passenger controls, passenger name records, vaccination certificates, contact tracing apps, all of these things which we developed, the green lanes, which Sandra was talking about, all of these things were designed to try and keep the economy moving at a high level of health protection. And we shouldn't throw these things away, because it took quite an effort to put them in place. So I think if we come back again in 5 years, I hope it'll be longer, but in 5 years' time, if we come back and we have to reinvent vaccine certificates, I wouldn't be very happy, because we've put in the work, we've created the tools. So let's try and keep them in a library of tools somewhere that they can be rolled out again. Some health measures are not cost-free. That's a key point, I think. And that, when you are taking health measures, you have to take a balanced approach and make them proportional, make them effective. On the gender and vulnerable groups, I think this is really important. In all of the groups I participated, including G7 group earlier on, this issue of the gender aspect of pandemic preparedness, it's certainly not in our current planning, and we need to include it. Also, vulnerable populations of all sorts were clearly, I was approached by the homeless organizations in Europe, and Europe is one of the richest regions in the world, and yet we were not able to protect our homeless populations in the same way as people living in their own apartments. So this is a real scandal, and I think we've got to learn the lessons and face the truth of there. That we've got to show an example as well, and put these vulnerable populations in a situation where they won't be exposed in the future. So on the non-communicable disease point, very important point. I mean, the NCDs were clearly a contributing factor to the gravity of COVID cases. This is something that wasn't on our radar at all. I mean, there were separate systems for non-communicable and for communicable disease. I can guarantee you these people were not speaking to each other. So having, looking at the mental health impact, for example, of pandemics is really important. And that's something which we will be doing in the coming months, at least on the European Union level, and I hope more widely as well, and making sure that our health systems are resilient. So investing in health systems so that they can operate in these sorts of extreme conditions, and they don't have to close down their cancer screening. They don't have to leave out people sitting in ambulances for 2 days, as happened in Europe. You know, so this is
frank with you. This requires, I will be very frank. Imagine there were people who had to go for screening. Sorry to spoil a bit your conclusions, but there were people that needed to go for screening, but the hospital would not be open for these people because they would say, we cannot take you in because we do not have like sort of a circuit which is safe for you to come in. So let me say to you all, it's not that we can devise buildings that have these perhaps in the future, having lived the pandemic, we will be much better, and we will, in let's say 1 or 2 weeks, create these circuits if the building allows that. But it's not easy to continue with the screening process if you have a whole lot of people coming in, you know, in ICUs with a very contagious disease. So let me be realistic. This requires a lot of resources, no?
Yeah, it certainly will. But I think what is useful in this sort of a discussion is we have different people sitting at the table. We're not just talking between the member states. We have health professionals, we have civil society. Yeah. We have different groups bringing their point of view to the discussion. And I think one of the impressive final points I'll mention is that many of these ideas came up in the G7 upstairs, in the G20 in Bali next week, in the World Bank, in the WHO and in the European Union and in other parts of the world as well. So I think we're all trying to learn lessons, and these sorts of events are very helpful. Thank you again.